Okay, good afternoon, everyone. I'm delighted to be here despite being a Sunday after a party yesterday. It's quite late in the afternoon. I hope you're all caffeinated and ready. We have a wonderful session coming. We're not gonna miss. We're not gonna waste any time, and we're gonna go straight for our next presenter. If I can invite Jessa Vandenberg to come to the stage. He works at at FAMO in the Netherlands, and he's going to be talking about the impact of the COVID pandemic in the Netherlands on primary healthcare use and clinical outcomes in people with type 2 diabetes. Well, are you ready?
Good afternoon. Thank you for the introduction and thank you for the opportunity to be able to present our work on the impact of the COVID-19 pandemic in the Netherlands on primary healthcare use and clinical outcomes in persons with type 2 diabetes. All authors have no relationships to disclose. So type 2 diabetes is one of the most common chronic diseases in the Netherlands, with an estimated prevalence of about 6%. Approximately 90% of chronic care for persons with type 2 diabetes is delivered by general practitioners in the Netherlands. And these general practitioners play a crucial role in providing regular checks of glycemic and cardiometabolic control in patients with diabetes. And one of the most important measures of diabetes control is hemoglobin A1C, which reflects the patient's average blood glucose levels over the past few months. And as high HbA1c levels are associated with an increased risk of complications, this regular monitoring by general practitioners is very important in both assessing and reducing the risk of micro and macrovascular complications in diabetes, such as nephropathy, retinopathy, and cardiovascular events. Especially in the first months of 2020, the COVID-19 pandemic severely disrupted routine healthcare delivery worldwide. And in the Netherlands, general practitioners were restricted in seeing their patients. Furthermore, patients were very hesitant to visit their doctor, especially persons with chronic diseases such as diabetes, as not to contract COVID. To this date, however, studies on impact of the pandemic on healthcare use and glycemic control in persons with diabetes are lacking, and so the impact of the pandemic on persons with type 2 diabetes remains relatively unknown. This study set out to examine the impact of the COVID-19 pandemic on primary type 2 diabetes care regarding the frequency of healthcare use, the frequency of clinical measurements, and the values of these clinical measurements. Additionally, we wanted to determine whether if changes differed between certain groups, which are persons aged below 70 years versus 70 or older, persons whose HbA1c was on target at baseline compared to those who were not on target, and patients with high-risk diabetes compared to patients with non-high-risk diabetes, according to the Dutch Diabetes Guideline for General Practitioners. Here too, we conducted a retrospective cohort study using data from the Diabetes Management and Treatment Cohort, also known as DIAMOND, which is a large and complete population-based dynamic and prospective cohort of persons with diabetes, derived from electronic medical records from around 20% of all Dutch general practices. We used this cohort to compare healthcare use and clinical outcomes in 2020 versus 2019, which is essentially a comparison between pre-COVID and during the first year of COVID. We selected all patients with type 2 diabetes with a date of diagnosis before 2019. Of these patients, we collected counts and values of HbA1c, body mass index, low-density lipoprotein cholesterol, and systolic blood pressure. Additionally, we collected counts of healthcare use for general practitioner total visits, office visits, home visits, and phone calls. This flow diagram shows the selection of patients. First, we selected all patients with type 2 diabetes from the DIAMOND cohort, resulting in around 289,000 persons with diabetes. We excluded patients with end of follow-up of less than 1 year of history before cohort entry date, which is at 1 March 2019. Also, patients with a type 2 diagnosis after cohort entry date and patients from practices that stopped contributing data before the end of the study period were excluded. And this resulted in a cohort of 182,000 patients with follow-up in 2019 And of these patients, around 168,000 patients still had follow-up in 2020. These graphs show in orange the frequency of performed measurements and in blue the average value of these measurements over the course of 2019 and 2020. And in gray is marked the first lockdown period in the Netherlands, from March to June 2020. We can see that the frequency of both HbA1c and body mass index measurements declined during the lockdown, and that the value of HbA1c increased. These are the same graphs, but then for LDL cholesterol and systolic blood pressure. Again, in orange, the frequency of performed measurements, and in blue, the average value of these measurements. Here we also see a large decrease in the frequency of these measurements during the lockdown period, but there is no clear trend in the average values of these measurements. We then use generalized estimating equation models to estimate values of clinical measurements in 2020 compared to 2019, taking both confounders and repeated measurements into account. The results of these analyses show a significant increase of HbA1c values in 2020 of around 1.65 millimole per mole. It is important to know that these analyses provide an estimate for differences between persons as well as within persons. Body mass index, LDL cholesterol, and blood pressure also changed significantly, but did so clinically less relevant. This forest plot shows the estimates of the HbA1c values in 2020 compared to 2019, where we stratified for certain high and low risk groups, as mentioned before. Patients who are at a lower risk at baseline, such as persons below 70 years, persons who met their HbA1c target, and non-high risk patients, all had a significantly greater increase than persons in their respective high risk groups. We then use negative binomial regression models to calculate adjusted rate ratios of healthcare use in 2020 compared to 2019. And the results show an increase of total visits to the general practitioner. Divided then into type of visits, the frequency office visit increased, but especially so for phone calls. And the home visits did not change in 2020 after adjusting for confounders. The increase in primary healthcare use is somewhat unexpected. In our sensitivity analysis, where we compared only the lockdown period in 2020 to the same calendar period in 2019, we noticed a decrease in healthcare use. And apparently, catch-up of care afterwards resulted in an overall increase of healthcare use in 2020. In contrast, the frequency of clinical measurements did decline in 2020. And this raises concerns about the quality of care for persons with type 2 diabetes that was delivered during the pandemic. The increase in HbA1c levels might have a delayed effect on the population of persons with diabetes, as higher glycemic levels are associated with complications of diabetes. Furthermore, worse outcomes of clinical measurements were seen in low-risk groups, while the healthcare use was comparable between these groups. This might aid general practitioners in assessing which patients are in need for checkup of diabetes control. So this study has several strengths and limitations. The Diamond cohort is a large and representative cohort of persons with diabetes. These results provide important insights into the impact of the COVID pandemic on diabetes care regarding both healthcare use and clinical outcomes. And these findings can aid general practitioners in identifying patients at risk for suboptimal control of their diabetes. A limitation is that the findings might not be generalizable to other countries with different diabetes care settings. So to conclude on the impact of the pandemic on persons with type 2 diabetes, primary healthcare use changed in 2020. There was a decrease in frequency of clinical measurements and an increase in general practitioner office visits and phone calls. HbA1c levels increased in 2020. There were no clinically relevant changes in body mass index, cholesterol, and blood pressure. And future research should focus on changes of incidence of diabetes and its complications, and also on possible changes in medication use. So thank you for your attention, and I'll be happy to answer any questions.
Fantastic, Jesse. Very good presentation and perfectly on time, which I really appreciate.
Thank you.
Any questions from the audience, please approach the microphone. The paper is open for questions. in the meantime, if I may, if I understand correctly, the study design, this is a cohort of people who are then followed up from 2019 to 2020.
Correct.
That obviously means that they are 1 year older than they were the year before. Could that account for some of your findings in terms of, increasing some of the measurements? What do you think about that?
Yeah, so that's a great question. And indeed, for persons who are a year older and diabetes progresses over a year, of course, their HbA1c might be higher on average, and also their BMI or blood pressure. But we try to account for this performing the generalized estimating equations models, which takes into account repeated measurements within persons. And it's also between persons. So we can say that between persons, it also changed, and not only within persons.
Okay. Any other questions? I hope Victor is approaching the microphone.
Just one question.
Can you introduce yourself, please?
I assume you calculated the rate of decrease in the testing of glucose levels. Could the decrease in testing be associated with a selection of individuals with higher risk? And could that account for some of what you found, do you think?
Okay, yeah, thank you for your question. So we try to describe indeed the frequency of measurements, and we saw a decline in the lockdown period. And you might say that the measurements that were performed during that period might be higher because of people that did come to the general practitioner, might really need their care, and might have a higher HbA1c on average than people who did not come to the GP. And we did also try to take into account that persons who visited their GP and did not visit their GP were not related to the outcomes of these clinical measurements. But again, for your question, I can say the same answer, that the GEE models provide an estimate for both between and within persons. So in that way, you can say that the increase is still true for some persons.
Thank you. Any other questions? Please introduce yourselves before asking the question so we know who is asking. If there's no other question from the audience, I had another one, if I may, just the data you have is beautiful, and it has enough granularity, I would say, to do some sort of time series modeling rather than just comparing as a kind of binary exposure. That would also help us to see whether, there is a trend that changes over time, or whether there is a kind of catch-up activity. Are you considering, or is this something that you're thinking of doing, some sort of, I don't know, interactive time series or any sort of time series?
Yes, indeed, we have thought about that. And also, because we update this cohort yearly, we now have also soon data available up until the end of 2022. So we can see if these trends persist over time. And also, when you do time trend analysis, it's difficult to do it with just 1 year of COVID. Well, yeah, you don't know whether it goes back to normal. So maybe now we can do these analyses you suggest.
Can you give us a teaser on what you're finding from?
We haven't performed it yet, but we want to, when the diamond cohort is ready for the next year.
Fantastic. Thank you.
Okay. Thank you.
I do have one quick question. I think if I noticed correctly on your flow diagram, there was a pretty significant difference in number of patients between 2019 and 2020. Do you have any information on those people that are not in both?
So the most of these people, I assume, are lost to follow up.
Do you have any? You don't have any information on
I don't have it stratified. I don't know it by heart, but of course there are diseased people in there, but not this amount. Okay. And then lost to follow up also contributes to this difference.
Yeah, I was just wondering what are the characteristics of those people, if you looked into that, to kind of maybe see whether that could also account for some of the things you see.
Yes, and it would be nice to have a cohort, which is, for instance, 2017, 2018, to compare a different time period in 2 years to see whether the changes are different in this time period.
Thank you.
Thank you.
Okay, with that, I think we can conclude. Thank you so much, Isa.
Okay, next we have Kyle Johnson from McGill University, and he will be talking about the impact of COVID-19 pandemic restrictions on diagnosis and treatment of hypertension in the United Kingdom.
All right, so hi everybody. Thank you for coming to the presentation and thank you for organizing this. As mentioned, I'm going to be speaking to you about the impact of COVID-19 pandemic restrictions on the management of hypertension in the United Kingdom. And we have the following disclosures. Okay, so as we've heard, and as I'm sure you are all aware, the COVID-19 pandemic had a profound impact on healthcare delivery. I'm sure we all know somebody or experience ourselves the difficulty of getting an appointment with the physician, or maybe there was some procedure delayed or canceled. And several studies in the United Kingdom have investigated the impact of this disruption in the context of cardiovascular disease. So it's been found that patients were more likely to die from cardiac arrest before they reached the hospital, that there was a decrease in the quality of care for diabetes patients, and there was a dramatic reduction in the number of dispensed cardiovascular medications, which was used as a proxy for diagnosis of these conditions. However, the impact of the pandemic restrictions on hypertension management in particular is understudied. And it's critical that we understand this impact because hypertension is a leading risk factor for cardiovascular morbidity and mortality, and its management is a key aspect of any strategy for cardiovascular prevention. So this motivated our primary objective, which is to describe the impact of the COVID-19 pandemic restrictions on the management of hypertension in primary care in the United Kingdom. And in particular, we wanted to focus on the impact on 3 different areas of hypertension management. So first is the impact on the diagnosis of hypertension. Second, the impact on rates of antihypertensive treatment initiation and change among patients with hypertension. And finally, the impact on rates of blood pressure monitoring among patients with hypertension. So to do this, we use the Clinical Practice Research Data Link, which is a primary care medical records database from the United Kingdom that contains data on over 60 million patients from over 2,000 general practices, and is generally representative of the UK population in terms of age and sex. We use this data to form a study cohort of all patients over 18 years old and registered with a contributing practice between January 1st, 2011 and March 31st, 2022. And we require them to have at least 1 year medical history before cohort entry. And for this cohort, we ended up with about 23 million patients. We then formed a sub-cohort of this study cohort of all patients newly diagnosed with hypertension within our study period, and we required 1 year medical history prior to diagnosis, no record of an antihypertensive medication use in this year, and we additionally censored patients 3 months after diagnosis if they did not receive a prescription in that time. And in this subcohort, we had about 700,000 patients. So the outcomes for the first objective was an incident hypertension diagnosis defined as the presence of a diagnostic code for hypertension, and this was measured in the study cohort. For objective 2, the outcomes were antihypertensive treatment initiation and antihypertensive treatment change, and these were measured in the hypertension subcohort. And for objective 3, the outcome was any form of blood pressure measurement, and again, this is measured in the hypertension subcohort. For statistical analysis, we calculated observed and expected monthly rates between January 1st, 2011 and March 31st, 2022. Expected rates were estimated using a negative binomial regression model that included a term for calendar month to account for seasonal variation and the number of months since the study start date to capture secular trends. We first fit this model to monthly event counts for each outcome from January 2011 to December 2019, using the amount of person time at risk as offset. And we then use this fitted model to predict expected monthly rates during the pandemic period from March 2020 to March 2022. And then we repeated this analysis after stratifying by sex, age group, and UK nation. So on to our results. In this plot, we see the observed and expected incidence rate of hypertension. And we see that before the pandemic, there was some seasonal variation around the average monthly rate of about 74 per 100,000 person months. But then in April of 2020, which was the first full month of lockdown in the United Kingdom, the rate of hypertension diagnosis fell to its minimum of 28 per 100,000 person months compared to its expected rate of 81 per 100,000 person months. And this represents a 65% reduction compared to historical trends. We also see that the rates did not approach the pre-pandemic levels until about July of 2021, which is 15 months after the initial lockdown. And we can get a sense of the effect of this prolonged depression in diagnosis rates if we look at the cumulative incidence rate of hypertension diagnosis. So we have, again, the expected and the observed, and we see that the observed is about 20% lower, which works out to approximately 51,000 potentially missing cases in our cohort. These are cases that we would have expected would be diagnosed, but we're not, according to our model. And so here we've stratified by sex, and I'm plotting the percentage difference between the observed and expected monthly rates of diagnosis. And we see that for both sexes, there was about a 65% reduction in April. But after that, women were consistently diagnosed at a rate closer to their pre-pandemic levels than men were. And by the end of our study period in March 2022, this meant that while there were 18% fewer women diagnosed than expected, there were 25% fewer men. Stratifying by nation, we see the interesting result that Scotland, in the gold line here, appears to have done much better at addressing the backlog of missing cases than other nations. So it is the only nation, or at least the first, that diagnosed people with hypertension at a rate above pre-pandemic levels, which would be what is required if you're to eat into the backlog of missing cases. And this elevated rate in Scotland meant that by March of 2022, we estimated that they diagnosed 2.6% fewer cases of hypertension than expected, compared to 20 to 30% in other nations. Okay, and so for the impact on treatment, we have again the plot of the observed and the expected monthly rates of treatment initiation among patients with hypertension. And we can see that the rates were relatively stable before the pandemic again, and there's pretty good agreement between our model and the observed rates. But then in April of 2020, there was a transient 47% reduction in the rate of treatment initiation. But quickly after, while the absolute number of antihypertensive treatment initiations dropped because the rate of diagnosis dropped, the rate of treatment initiation jumped above expected levels and remained there until March of 2022. And in the end, we estimated that the observed cumulative incidence rate of treatment initiation was about 35% higher than expected. For rates of treatment change, we see a similar reduction in April of 2020, but rates soon settled back at the expected levels after jumping up a bit above expected in July of 2020. So when we stratify by sex, here I'm plotting the difference between the observed and expected cumulative incidence rate of treatment initiation. We see that there's not much variation. So the excess treatment initiations are relatively evenly distributed between the sexes. But when we plot stratify by UK nation, we do see some variation. So England and Scotland appear to have prescribed antibiotic treatment at a rate higher than Wales and Scotland. And for this and the previous outcome, I didn't show the results for age because there wasn't much variation in the age groups, and for the sake of time. And I'm doing the same for the treatment rates of treatment change. There was not very much variation between sex and region. Okay, and so for our third objective, the impact on blood pressure monitoring. Again, this is the observed rate and the expected rate. And in April of 2020, there was a 69% reduction in observed rates of blood pressure measurement in patients with hypertension. And rates did recover in about October of 2020, which coincides with the National Health Service in England beginning to distribute home blood pressure monitoring kits, which may have aided in the subsequent recovery. So what are the implications? We see that rates of hypertension diagnosis, treatment, and monitoring were all significantly impacted by the COVID-19 pandemic. We estimated that there were more than 50,000 missing cases or potentially missing cases of hypertension in our cohort who, because they have not been diagnosed and treated, are at elevated cardiovascular risk and must be identified. We didn't observe variation by age, but there were possible sex differences in the rate of recovery and diagnosis rates, which may mean worse outcomes for men in the future. And we also saw that Scotland performed much better at other nations at addressing the backlog of missing cases, which may be the subject of future research. There was a significant reduction in rates of blood pressure monitoring that could have led to suboptimal treatment decisions. So if a patient had uncontrolled blood pressure and a physician was unaware because they hadn't measured it, they may remain on inappropriate treatment longer. However, we did observe only a small effect on rates of treatment change, which may suggest little to no effect on clinical inertia in patients with hypertension. And finally, we saw that physicians appear to be prescribing antihypertensive medications sooner after diagnosis following the pandemic than they did before. And this seems to have persisted until at least March of 2022 and was stronger in England and Scotland and less so in Wales and Northern Ireland. So thank you.
Okay, you can go ahead.
If I may, excellent presentation, Ankel. I don't know how much it made it in news this side of the ocean, but you know, in the UK, the different nations or countries within the UK made very different decisions at different time points. I was wondering whether because in a way your exposure here was like NPIs in general, but those differed by nation, they differed over time. And I think you have here a unique opportunity to do some sort of causal analysis, like, you know, using difference in differences or something like that, looking at what happened when, you know, one part of the country did one thing, but the other didn't, because everything else, you know, is the same NHS, is, you know, it's the same country really, right? So I was wondering whether you have any thoughts on that and if there are any plans to look into that.
Yeah, I think that's a great point. Yeah, as you said, the different countries had different approaches to the pandemic. I think in Scotland, for instance, there were regional restrictions in October of 2020, and then in November, England went into a lockdown, whereas Scotland didn't, which may have affected things. But in January, Scotland did go into lockdown with the other nations. But I think I don't know if I have a good answer for why, but I do agree with you that it would be very interesting to try to dig down into the regional difference and see correlate, as you said, the different strategies and see how that affected the rates. That's a good point. Thank you.
Anybody? If not, I have a quick question more like on the details of your design. And I if I remember correctly, you said something about censoring 3 months after diagnosis if they were not initiating treatment. Can you comment a little bit on the decision and why you censored there?
Yeah, so we were most interested in the people who do initiate soon after, which that seems to be a decision that may be more, it's a slightly different, I guess, population. And practically, it also helped us address some issues with rates being artificially inflated at the beginning of follow-up because we don't have the prevalent hypertension cases, so we hadn't accumulated enough follow-up time. But it was the same before the pandemic and after. So I don't imagine it made much of a difference because the vast majority of hypertension patients did get prescribed before 3 months as well.
I don't know if that's the case in UK, but I would think there would be some that at least start on non-pharmacological, and then maybe with monitoring, the decision is made for treatment. So I don't know exactly whether it's within 3 months or later, but maybe something to consider.
It'd be worth exploring.
Frederick Nyberg, University of Gothenburg. You talked about the backlog of hypertension diagnosis, but I guess there's some would also just be simply missing because people died also.
That's true.
But that would probably be a small proportion. Have you tried to estimate how much of that might be truly missing and just backlog?
Yeah, I mean, the backlog, so we're estimating it based on the historical trends. And I think if the death rates are going to be the same relatively the same, it might not be affecting it that much. If there is excess death, that may missing cases because more people are dying. But if the people are dying at the same rate before, I think that would also
but there was some excess there.
Yeah.
That's my point. But
Yeah.
I guess it would be just a
I
small
would think
proportion.
I would think it's quite small.
Yeah.
Yeah.
Okay.
I think for the sake of time, we'll move to the next presentation. Thank you so much for your presentation.
Thank
If I can invite, please, Catherine Callaway-Kim to come to the stage. He's going to be talking about the impact of the COVID pandemic on drug shortage incidents in the United States.
Great. Hi, everyone. Good afternoon. I'm Catherine Callaway-Kim, and I'm going to present our group's work on the impact of COVID-19 on drug shortages in the US. These are our disclosures. And so pharmaceutical supply chain issues in the US are the highest they've been since 2014. The graph on the right here shows the number of supply chain issues reported to the American Society of Health System Pharmacists, which reached 309 last quarter. We all know that COVID-19 really worsened global drug supply chains. This included manufacturing shutdowns during national lockdowns, export bans, as well as unprecedented demand for COVID-19 treatments and other products. But it's important to note that these aren't necessarily new problems. So drug shortages are a chronic issue and are defined by the US FDA as a period in time when demand for medication in the United States exceeds supply. This can really greatly compromise patient care, especially if it leads to missed or delayed dosages, medication errors, or increased drug costs. One of the complicated things about studying this is that drug supply chains are complicated by definition. So not all of reports that are given to FDA necessarily result in meaningful decreases in supply. Since 2012, manufacturers are required to report issues which they think are likely to impact national supply, but we don't really know what that subsequent impact is. Here you see a conceptual model by the National Academies of Medicine, which sort of demonstrates how FDA can work with manufacturers to either mitigate the impact of upstream issues or institute preparedness measures such as backup inventory or national stockpiles. And the key thing with our research is what we were really interested in was seeing how many of these upstream issues, not only their incidence, but also their downstream impact on actual drug purchasing. And so our primary study objective was therefore to determine the proportion of US FDA or ASHP supply chain issues, which resulted in shortages during versus before the COVID-19 public health emergency. And to do this, we used a comprehensive national purchasing drug data set, and we defined a shortage as a greater than or equal to 33% decrease in total supply using this national sales data. This is consistent, again, with the US FDA's definition of a shortage and is greater than what would be expected based on seasonal trends. So in the graph here, I just show two examples, one of a supply chain issue report from a manufacturer, which did not result in a shortage. So you can see in the blue line that verapamil supplies remained fairly consistent after the issuance of this report. And then another example of a supply chain issue that did result in a shortage. So hydrochlorothiazide valsartan was recalled by the FDA in 2018, and you can see that then supplies of this drug decreased by 40 to 50% in the subsequent quarters. So for the purpose of our analysis, that's what we are defining as a shortage, and the other scenario would just be a supply chain issue report. Our data source was the IQVIA MIDAS dataset, which is a serial cross-section of all drugs purchased in the United States. Drugs are defined on the ingredient formulation level, and this dataset captures 85% of retail and 97% of non-retail drug purchases. We did restrict to prescription products, just since the data set doesn't fully capture over-the-counter drugs. For each drug with a supply chain issue, we then matched to 10 comparison drugs just on the month of that supply chain issue report. So again, this is a serial cross-section. For each month with supply issue report, we identified the drug with a report and then up to 10 drugs with no report. We didn't match on any other variable, just because we know that the supply chain risk for drugs that do have issues is very different than those without issues, and we wanted to maintain that real-world heterogeneity. We then used random effect logistic regression to compare the marginal odds of shortage for drugs with versus without issues, both prior to and during COVID-19. Again, here a shortage is a greater than equal to 33% decrease in supply. Overall, we had 1,800 drugs in our data set, of which 571 had at least one supply chain issue from 2017 through 2021. You can see here we grouped these sort of based on the pandemic period using previous global drug purchasing trends. And a large proportion of these had no reason given for the supply chain issue report. Reporting the reason was not required by law until during the pandemic, so this is consistent with previous studies. And also consistent with previous studies, older generic drugs had a much higher risk of having these supply chain issue reports. So these included drugs with greater than 5 manufacturers, drugs on WHO's essential medicine list, as well as those with generics available and who were by definition older. So this is our overall findings for the impact of COVID on drug shortages. The y-axis is the marginal predicted percent of medications with a shortage. Again, we're defining this as a greater than or equal to 33% decrease in supply within 6 months after the issuance of a supply chain issue report. So in the blue, you can see that prior to the pandemic, about 13.7% of reports went on to have shortages, compared to only 4% of drugs with no report. Both groups increased dramatically in the first few months of the COVID-19 pandemic and then returned to pre-pandemic levels. That middle group only included 57 reports, and so it was a smaller sample size, meaning that our confidence intervals did overlap for the difference between the drugs in those first initial COVID months versus pre-pandemic. We also noted some heterogeneity in terms of drug characteristics. So WHO essential medicines were less likely to have shortages when upstream reports occurred. And brand name medications, which by definition only have one manufacturer, were much more likely to then have decreases in supply when there was an issue at that manufacturer. Sensitivity analyses using different data sets to define supply chain issue reports and extending our study period to look for shortages, as well as matching drugs on more baseline characteristics, were largely consistent with our main results. And some limitations of our data do include that we don't have full information on over-the-counter drugs. This is also aggregated on a national level. So a lot of the drug shortages work indicates that the availability of medications may really differ by region or health system purchasing power, which we weren't able to look at here, but are planning to do in future work. And we also, the session this morning about data quality during COVID, I think made the good point that we're really relying on what is reported during the pandemic to flag issues during that time period. And we do know that FDA, had a lot going on. And so maybe wasn't, the reporting may have had competing priorities during those initial months. So conclusions and implication for policy, drug shortages are definitely still a problem and increased at the start of the pandemic, then returning to pre-pandemic levels. Even though supply chain issues are still more common for generic products, single source production may increase risk for downstream shortages. And future policies should really prioritize clinically valuable drugs at high risk of shortage. I'd also like to note that shortages aren't going away just as the pandemic is ending. So this picture here shows a hurricane which really impacted a Pfizer facility in North Carolina just last month. So we really need to continue to prepare supply chains for unexpected events, especially those around climate change. And with that, we'll take any questions.
Fascinating and very intriguing presentation. Open for questions.
Hi, I'm Teresa. I'm from Oxford, and I actually have two questions, if I may. But so the first one is, when you say the exposure was supply, what do you mean? Is like frequency of packages sold or frequency of packages manufactured? What do you mean exactly by supply?
Yeah, so we were measuring supply using drug purchases. So our data set is purchases from either the pharmacy, from a wholesaler, or the drug manufacturer themselves. So it's sort of stock in the pharmacy that's been purchased. It's not necessarily like dispensings to patients.
Okay, so you were quite lucky that you had this information available, I guess.
Yes, yeah. IQVIA has been great to work with. So
okay, cool. And my second question is, with the 33% decrease, is there any other definitions, or is this the standard one, or do you sometimes elaborate on that a bit?
Yeah, so finding a consistent definition for a shortage is very tricky. The FDA defines it as a meaningful decrease. They don't really have a certain cutoff. And so we chose the 33% sort of using what other authors had done in the past. And then we did look at the seasonal trends, and just kind of qualitatively found that 10% is kind of normal with seasonality. And so we wanted to get something that was greater than that. We also, I didn't show it here, but we did look at ones that had a greater than 66% decrease, and kind of characterize those as severe shortages. And our results were largely consistent for those.
Thank you very much. If there's no other question, I had one in mind that I wanted to ask. So I guess if the title of your talk is Impact of the COVID Pandemic, I'm assuming you are kind of attributing causality to what you're observing. And I was wondering whether you had the opportunity to look at specific medications that we know would be more impacted because they were being overused during the pandemic, or, well, adequately used potentially, but used more than before. I don't know, tocilizumab, some steroids, hydroxychloroquine. Did you have the opportunity to look specifically into those COVID therapies?
So we are still, this is part of a larger grant by my mentor, Dr. Katie Suda, and that's actually our next step, is going even further downstream. So I mentioned that this was sort of looking at purchasing data, so like supply at the pharmacy level. We're going to do this with using patient dispensing data to see if that actually reached patients. And then we have some really cool case studies, including ones like drugs used in the intensive care unit, some of these like asthma drugs, and are really going to see, using more granular data, how those impacted patients and supply and purchasing for those medications. It's a little tricky with this data set just because it is sort of very aggregated on a national level. And so we wanted to sort of give an overall picture, but for sure gonna look at those events.
Kind of related to that, one of the issues I had with the definition of shortage that you're using is that, as you said initially, it could be that, for instance, you could see an increase in sales as a result of a predicted future shortage because people are stockpiling. And similarly, you could see a reduction in sales due to less need or appetite, like, when we found out that hydroxychloroquine was not any good for COVID, potentially people were buying less, hopefully. So I don't know if you have any thoughts about,
We do, yeah, and we struggled with this a lot. And so if you look at this graph here, that initial February through April period, in previous work, we did see that the US in particular had really increased their purchases for, for example, medications used in the intensive care unit. And then that really plummeted because they had sort of stockpiled those drugs, anticipating that this pandemic was coming. And so that's actually why we wanted to match these drugs to drugs without an upstream report, so that we were hopefully accounting for that kind of stockpiling behavior that was across the board. It's obviously not perfect, but was sort of our best attempt to get at a more causal estimate.
Thank you. Thank you so much. I think in the interest of time, I'm going to go for the next presentation. Thanks so much.
Okay, and next we will have Priyanka Anand from Brigham and Women's Hospital. She will be presenting a dynamic prognostic model for identifying vulnerable COVID-19 patients at risk of rapid deterioration.
Hi, everyone. Thank you for being here. It's late on a Sunday afternoon, and I appreciate the opportunity to talk about our study, which is a dynamic prognostic model for identifying vulnerable COVID-19 patients at high risk of rapid deterioration. These are my colleagues at the Brigham who worked on this study. The study was funded by a grant from the NIH, and this slide has all our disclosures. So, here we are, we're still talking about COVID more than almost 4 years after it was first diagnosed. It's still a persistent global threat and it has placed an unprecedented toll on healthcare organizations worldwide. We've made large public health gains in terms of global vaccination efforts, but those infected with COVID, especially the older population and those with multiple comorbidities, still face significant mortality and morbidity from the illness. So in this context, and also because the health status of these patients who are hospitalized for COVID, the health status can deteriorate rapidly. A daily risk stratification tool becomes important for clinicians to provide targeted treatment, to manage bed flow, and also to perform triage. We previously built a prediction model to determine severity progression in patients hospitalized with COVID. The model performed fairly well, but the model was developed and validated using data before the availability of vaccines. So its generalizability in this post-vaccination era is still not established. So therefore, in this study, we aim to prospectively validate this prognostic model, and if needed, to further update the model using data with vaccines. For this study, we use the Research Patient Data Registry, which is essentially the electronic health record of the Mass General Brigham network. Along with clinical information, we have information about demographics and death information. Mass General Brigham is a large care delivery network in Massachusetts. It consists of 2 tertiary hospitals, 11 secondary hospitals, and more than 30 ambulatory centers. The study population consisted of patients who were 18 years or older and who were hospitalized at an MGB facility from the start of March 2020 to November 2021. We required that these patients had an RT-PCR confirmed COVID-19 infections. To ensure that we had included only true hospitalizations, we excluded patients who were discharged on the same day of admission, who received hospice or comfort care, and also patients who had no labs drawn in the first 2 days of hospitalization. We had a very small number of pregnant patients in our study sample, so we excluded this special population from our final cohort. The primary outcome was rapid disease progression or death within 24 hours of hospitalization. We define rapid disease progression if a patient moved up 2 levels, at least on the severity scale, in 24 hours, or they died. A follow-up began on the day after cohort entry, and it continued until the outcome occurred, the patient was discharged, or the end of study data. Prognostic covariates included fixed and time-varying predictors. Fixed predictors were, of course, they didn't change during follow-up. It included demographics, general health status like BMI and COVID vaccination, and also chronic conditions and medication use for chronic conditions. These predictors were measured in the 365 days before cohort entry or on the day of cohort entry. Time-varying predictors included labs and vitals, which were measured on each day of hospitalization starting at cohort entry. To account for missing data, we did multiple imputation. Day zero values of continuous variables, that's labs and vitals, were imputed using the missing at random assumption. For values missing after day zero, we use the last value carry forward. Model development and validation were conducted on the imputed dataset. The original prognostic model used data up to October 31st, 2020. So to prospectively validate the model, we used data from November 1st, 2020 to June 1st, actually it's November 1st, 2021, this is a typo. And we used model, and we did model validation by Brier score and AUC. To update the model, we took the entire data set, we randomly divided it into a 70% development and 30% validation cohort. We did model development in 2 stages. The first step was a 10-fold cross-validated lasso regression. We included all day zero values of predictors and entered them into a cross-validated lasso regression. In the second step, we took the features that were selected by lasso plus the change value of the time-varying predictors and put them into a generalized estimating equation model to estimate the predicted probability of the outcome, which we, and then we used Brier score and AUC for model validation. So here are the results. There were about 81, 85 patients in our final analytic cohort with a median follow-up of 6 days. Around early June, more than 50% of the Massachusetts state population were vaccinated against COVID. So in hospitalizations after this date, we saw that patients were younger, they were predominantly white, and less likely to have comorbidities. A full vaccination regimen was in place, but still we had a high percentage of unvaccinated individuals in our cohort at over 85%. In the original development data set of the original model, the AUC was 0.81 and the Brier score was 0.03. In the validation data set, that is the data after using data after November 1st, 2020, the AUC went down to 0.6 and the Brier score went up to 0.1, showing like a worsening of model performance. In the new model, so we went ahead and developed a new model. In the new model, there were about 5,700 patients in the development data set and 2,400 patients in the validation data set. The variables selected by Lasso included age and COVID vaccination status, as well as 16 comorbidities like lung cancer, diabetes, type 2 diabetes, and also 20 time-varying labs and vitals. All these features plus the change value from previous days entered into a GE model, and these coefficients are included in the handout. In the development dataset, the Brier score now was 0.016 with an AUC of 0.79. In the validation dataset, the AUC was 0.76 with a Brier score of 0.017. So the previous model did perform well before the availability of vaccines. But one of the highlights of our study is that we could use data from both the pre and post-vaccination era. We had a larger cohort size and with more outcome events. On the other hand, we were limited by the high proportion of unvaccinated individuals and also by the fact that we could not distinguish between individuals who received just 1 dose of the initial COVID regimen versus those who received like the complete 2 doses for the Moderna and Pfizer vaccines. Also, we measured baseline characteristics in the 365 days before cohort entry. So there is room for misclassification if the covariates were recorded before this period and also out of the MGB network. So in conclusion, based on data from this large healthcare system in Massachusetts, we found that a model predicting rapid severity progression, which was developed in the pre-vaccine era, did not generalize well to the post-vaccine population hospitalized for COVID. So we updated the model using data from the post-vaccination era, and we achieved satisfactory model performance in a held-out validation data set. The model can serve as a decision tool to help clinicians make decisions regarding treatment initiation, care escalation, or de-escalation. So with that, I will end my presentation, and thank you for you.
Thank you very much. Please come forward. Thank you.
Hello, nice presentation. Hector Isurieta, FDA. I have a few questions. You use vaccination as the separation point, but I was thinking also that maybe it would be useful to see the effect of the different variants, which are, higher transmissibility, but lower severity as time went by up to the Omicron variants, and also the prior experience with another variant. So the longer we move into the pandemic, the higher the likelihood of a prior infection, and prior infections, particularly within the 6 months prior, decrease severity in people who get infected. But I know it gets complicated, but did you account for any of that, or are you thinking on doing that?
No, we did. That's an excellent question. And you bring up a really good point, which is that the pandemic is rapidly evolving. By the time we get a data set, there is a new strain, and there are new vaccine, new ways of which we manage the pandemic. So that highlights also like a big reason why there was a drop in performance of the model. But yeah, we were not able to account for anything in this study, but moving ahead, that would be something very interesting to look at. Thank you.
Anybody else? If not, I do have a question. I know you said you talked about the validation and splitting the data set. Is there an option to maybe validate outside of your hospital system and in a different setting and see how the performance?
Oh, I think it's absolutely necessary, even before using this model, again, because things are changing so rapidly. It's absolutely necessary to validate that in a system like outside of our healthcare system, and also outside of the time period in which we used. So yeah. And
related to that, you mentioned how you addressed missingness. Is there something like, was there a particular variable that was important and was imputed, or was it kind of spread with multiple variables?
There was missingness with relation to quite a few variables, but we had this cutoff that if missingness was more than 40%, we were just going to drop it from our model. If missingness was 40% or less, we then imputed it. Yes, so
thank you.
Ben Loray from the University of Pennsylvania. Really nice talk. One of the key variables in your model was general health status. And you said that general health status was defined as a fixed variable within 365 days prior to the hospitalization. And I'm curious what went into that variable. And I'm curious that, health status could change over a course of a year. How did you deal with those changes over that course, and how might that have impacted the model?
Yep. So when I said general health status, it included things like BMI, smoking status, COVID vaccination. And we did look back 365 days before cohort entry, but we took the value that was closest to cohort entry into our model when we used it.
Okay. Thank you.
Thank you.
Yes, if I can invite Noel Kokoros from Harvard Pilgrim Healthcare Institute, who's going to be speaking about hospitalized arterial and venous thromboembolic events in patients diagnosed in the ambulatory setting with COVID-19 compared to influenza. Whenever you're ready, Noel.
Hi, everyone. Good afternoon. Thanks for being here. Noelle Kokoris. I'm very happy to be presenting this on behalf of a very large project team. Here are our disclosures. So as background, many of you, if not everyone in this room, probably remembers early in the pandemic, there was a fair amount of discussion both in the medical and scientific literature as well as in the popular media around arterial and venous thrombotic complications among people with COVID. And it was really focused early on small case series and focused on not just hospitalized patients, but also those receiving critical care or in the ICU. And over time, work expanded in this area with larger, much more robust studies, and but still generally focused on hospitalized patients, at least in terms of where their initial COVID diagnosis occurred. And so this same project team actually did work in that setting. So we looked at people with hospitalized with COVID, also hospitalized with influenza in the prior flu season, and looked at venous and arterial thrombotic events. And very briefly, we saw an increased risk of venous thrombotic events among people with COVID compared to flu, like a little bit of a suggestion there might be something going on with arterial thrombotic events, but not clear. And then among people who had had one of those events, they were at increased risk of mortality if they had COVID compared to flu. There's been many others who have published in this area, relatively speaking, at this point. But what's less clear is what happens or happened to people who are initially diagnosed in the ambulatory setting, because they will be quite different. And so that's what this is focused on. So our aims were to look at people with COVID-19 and seasonal influenza in the year prior to the pandemic, calculate the 90-day incidence of arterial and venous thrombotic events. And we are always looking at those events separately, then compare the risk of those two event types for COVID versus flu, and then also look at the risk of mortality within 30 days of one of those events. And we looked at so we basically have two COVID cohorts, one before vaccine availability and one after, and I'll talk a little bit more about that, of course. So this was an FDA-funded study conducted within the Sentinel system. We used a version of our sort of main Sentinel data that we call our rapid Sentinel database. And this was developed in response to the pandemic to basically get claims data more frequently available so that they're fresher for use. And so it has a subset of all of the Sentinel data partners. And so in this study, we had 4 integrated regional health systems in the United States and 2 large national insurers. So a retrospective cohort design limited to adults. And we identified COVID and flu, again, in the ambulatory setting. So it means outpatient encounters or ED visits. And they were identified either by an infection-specific diagnosis code or a positive nucleic acid amplification test. The outcomes were identified in the inpatient setting by diagnosis code exclusively. We had some access to lab data and identified pre-existing comorbidities and prior outpatient medication use in the classic way using claims data. So a little bit more on our study patients. On the far right-hand side, you can see the influenza cohort. So again, this was the 2018-19 flu season. So the season immediately preceding the pandemic. This ensured none of these patients also had COVID. And the COVID cohorts on the far right-hand, or on the left-hand side rather, those are the 2 cohorts, one identified before the vaccine was available and period 2 is after the vaccine was available. So importantly, we did not take into account vaccine status on the individual level. We just took it into account in terms of basically the 2 different cohorts. Everyone was required to have at least a year of both medical and drug coverage prior to entry into the cohort. And to the degree that we were able to in claims data, we excluded people who had any evidence of a co-infection with another respiratory virus. And importantly, our outcomes are not incident outcomes. So we did not restrict to people having just a new arterial or venous thrombotic event, and instead allowed people to have a history. We included that history in our propensity scores. We also did some subgroup analyses as well. So a little bit more on the outcomes of interest. So arterial thrombosis, we defined as an acute ischemic or embolic stroke or an acute MI. Venous thromboembolism was acute upper or lower deep vein thrombosis or acute pulmonary embolism. These are identified exclusively by ICD-10 diagnosis codes in any position. We derived our code list by using algorithms that had previously been validated, but from the ICD-9 era in the Sentinel system, mapped those to ICD-10s, and then each code was reviewed by clinicians on our project team. So very briefly, in terms of our analyses, we calculated absolute risks. So simple absolute risks for our 3 cohorts. We just describe our cohorts extensively, which I'll show you a little bit in a moment, and also calculate the absolute risk of death within 30 days of one of the primary outcomes. For our comparison of COVID versus flu, we used propensity score fine stratification and weighted Cox regression to take into account the propensity scores, and we also adjusted for the different data partners. So now I'll show you some of the data. So this is just a snapshot of sort of a classic table 1. This is a short list of the covariates that were included in the propensity score model, excluding the one on the bottom row, but it gives you some sense of the cohort. So you can see, and I'm also just showing you part of the period 1. This is the period 1 cohort for COVID only. Our period 2 cohort, which was after vaccine availability, the results are quite similar. So we had about 272,000 people with COVID in the first period before vaccine availability, about 119,000 people with seasonal influenza. The information in the middle is prior to propensity score adjustment, and then the far right-hand side are the standardized mean differences after propensity score adjustment. So before taking into account propensity scores, the COVID cohorts were a little bit older, had more of certain underlying conditions like chronic kidney disease, diabetes, and hypertension. The flu cohort, not surprisingly, had more evidence of underlying respiratory illness, such as asthma and COPD. After propensity score adjustment, the cohorts were quite balanced when we compared flu and COVID. And then on the bottom, this is an important data to take into account. This is the proportion of the cohorts who are identified with a positive lab test versus a diagnosis code. So it's quite low in the flu cohort, I would say, not surprisingly, and a little bit better in the COVID cohort, but still heavily reliant on diagnosis codes to get into the cohort. So I'm going to show you 4 slides of the primary results, 2 for arterial thrombotic events, 2 for venous, and they are laid out in the same way. And so you've got the flu cohort on the top row, then the period 1 and period 2 cohorts for COVID. In the middle is the simple absolute risks, and you can get a sense of, for flu is 0.5% for an arterial thrombotic event, about 1% for COVID. And then the far right-hand side is the adjusted hazard ratio for both propensity score and site adjusted. And you can see that for people with COVID, they had increased hazard of an arterial thrombotic event compared to those with influenza, and that was for both COVID cohorts before and after vaccine availability. And then this is the the mortality data following having one of these hospitalized arterial thrombotic events. And so you can see here, again, on the far right-hand side is the fully adjusted hazard ratio. And you can see that those with COVID who had one of these arterial events were at increased risk of mortality compared to people with influenza who had had one of these arterial thrombotic events, with point estimates of about 2.5 to 2.7, depending on the period. So then same setup for venous thrombotic events, somewhat similar results, although the point estimates are higher here when you compare COVID to flu. And so you can see the absolute risk is lower, 0.2% compared to arterial, 0.2% for flu, and then about 0.8, 0.7% for COVID. And then you can see the adjusted hazard ratios on the far right-hand side with about 3, a hazard ratio of about 3 for COVID compared to influenza for a venous thrombotic event. And then the mortality results are relatively similar to the arterial thrombotic event. So again, this is mortality following a venous thrombotic event, and it was higher for COVID compared to influenza. So those are the primary analyses from this study, but this is a reasonably long but not exhaustive list of things to take into account. So I won't read through all these, but some of the things that are most important to be aware of is that our outcomes, we did not validate our outcomes in this study, although our code lists were derived from previously validated ICD-9 algorithms. And importantly, early in the project, we did a small chart review within the integrated delivery systems to see how we were doing with identifying these outcomes, and they held up pretty well. We also did a fair amount of review of the specific diagnosis codes of the people with the outcomes, and they made sense, and we felt rest assured in that. A really important point is the likely undercapture of outcomes for COVID-19. So in claims data, as everyone in this room probably knows, in the US, it takes a long time, especially for inpatient information to get complete, but you can get near complete within a few months. It sort of varies by partner. And so we waited for that. We waited for the inpatient data to be near complete so we could be confident in our decent capture or pretty good capture of the outcomes of interest, but we know for sure that out of hospital death was under captured. It takes quite a long time for out of hospital death to be settled in claims data. So that's an important thing to keep in mind. We only looked at one flu season. We did that intentionally so that it was closest to the start of the pandemic. It was one considered of moderate severity. So that's important to keep in mind. And then a couple points on data availability. As I mentioned, we did not take into account vaccination status. There have been sessions I mentioned in multiple sessions here the last few days about the incompleteness of vaccine capture in claims data in the United States when vaccines are given outside of typical clinical practices. And so we knew that and did not want to have a ton of misclassification. And so instead just looked at the 2 periods. We also did not take into account inpatient care due to the challenges of understanding timing of care in the inpatient setting in claims data. So in conclusion, ambulatory patients who were diagnosed with COVID, both before and after vaccine availability, had a higher risk of inpatient arterial and venous thrombotic events when compared to people with seasonal influenza, at least in the 2018-19 flu season. And then among those who had one of these outcomes, the risk of mortality was 2 to 3 times higher for those with COVID versus flu. And this is a list of the project team, and thanks very much for your attention.
Okay, paper is now open for questions. Otherwise, I might kick off. Thank you, Niall. That's a very elegant presentation. I was wondering, in terms of the comparison with flu, which is always tricky, right? And I appreciate you did your best with propensity scores and everything. But I was wondering whether whether you think, or maybe you could even look at this, where there is more proactive imaging, testing, seeking or looking for blood clots in people with COVID, and particularly in the latest stage of the pandemic, as we have already learned that there is an association. I don't know if you have data in your...
Yeah, I mean, we've not looked at it, but you certainly could, relatively easily look at frequency of certain procedures. So we could certainly have done that. We could certainly do that. I mean, this is part of why we looked at the people identified with COVID and flu first in the inpatient setting and then separately first in the ambulatory setting, understanding sort of differences in how flu patients might be treated compared to COVID. Our general assumption, at least in the hospitalized, that the prior study that we did was that if you're hospitalized and you've got one of these infections, chances are you're going to be treated pretty close to the same way. And so, but we still thought it was important to look for those identified in the ambulatory setting. So I think there's still issues, even though we had good balance and we didn't look at inpatient care, but certainly something we could do.
Thank you. Do you have any questions? Otherwise, if we still have a second, I don't know if you could expand a little bit on the mortality completeness issue for people who are not based in the
Yeah, happy to. So for those of you who have the good fortune of maybe having different data sources in other countries that are more complete, maybe more quickly. So we defined mortality here, and we often do this, although it kind of varies. We defined it as either an in-hospital, basically discharge status of deceased, or evidence of death captured outside of that hospitalization. It was mostly in hospital death. So what happens is that if you die in the hospital, or a person dies in the hospital, that will get to their insurance company. But the death data for out of hospital deaths just takes a very long time to essentially get to the insurance company. That's the sort of short answer.
Good. Thank you so much. Okay, I think we can close this presentation here. Thank you so much.
Okay, and to close this session, we have Katie Anderson. She'll be presenting in defining post-COVID conditions using changes in symptomatology in electronic health record data from the United States.
Hi, everyone. I'm Katie Anderson. I'm Director of mRNA Vaccine Real World Evidence at Pfizer. and I'm here today on behalf of co-authors to bring our results towards defining post-COVID conditions using changes in symptomatology and electronic health record data from the United States. This research does not involve a Pfizer product. However, all authors are either Pfizer employees and may hold stock or receive consulting fees from Pfizer. The definition of post-COVID conditions, PCC, sometimes referred to as long COVID, is constantly evolving. Within PCC, there is not yet consensus on which symptoms or conditions, what level of severity and/or duration define the syndrome. And here on the slide, you'll see a brief presentation of each of the United States, World Health Organization, and UK definitions. Our objective was to create a data-driven definition of PCC by directly identifying changes in symptomatology before and after a first COVID episode. First, we created a population of people with COVID using an electronic health record from Optum, de-identified data in the United States. We polled people with a healthcare system encounter from April 1st, 2020 through September 30th of 2021. We used persons of any age, defined as having COVID with either an ICD-10 code of US 7.1 and or a positive test result from a PCR or an antigen test. For each person with COVID, we also selected up to 3 comparators from Optum using a caliper of 0.1 standard deviations of a propensity score. And that score contained each person's sex, race and ethnicity, insurance payer, whether they were overweight or obese, they were a current or former smoker, as well as their Charlson Comorbidity Index score. We further required this comparator pool to be within 1 year of age of each COVID person, have had a healthcare system encounter in the same month, and not have had prior documented COVID. In order to untangle which signs and symptoms were more frequently occurring after COVID episodes, rather than occurring at background expected rates, we compared symptoms and severity to relevant comparators. We selected all patients with COVID, denoted in dark blue, as well as a set of non-COVID comparators in lighter blue that are most like each COVID patient. The prevalence of each symptom was computed within the post-COVID as well as comparator populations, and then the ratio of this symptom prevalence is computed to generate a prevalence vector. Prevalence ratios quantified whether symptoms were more or less prevalent in persons post-COVID compared to the control group. We then created a symptom significance vector, which we normalized by the prevalence ratio as well as severity. Here on this slide, you'll see a hypothetical person with COVID who has pre-existing hyperlipidemia in gray. After contracting COVID, this patient developed both shortness of breath in green, as well as inflammation in pink. In their post-COVID period, which in the United States is generally defined as 4 or more weeks after, this hypothetical person recovered from their inflammation, but their shortness of breath persisted, and their persistent novel symptoms are encoded in a binary vector. We then took the dot product of this symptom vector with the prevalence vector from the previous step. And a person has post-COVID conditions if the dot product between symptom and prevalence is greater than 1. In other words, if they had a condition that persisted and it was also one of those ICD-10 subchapters, which was more common after COVID than in the comparator population. For the subset of COVID cases that were diagnosed in September of 2021, we had a unique opportunity to compare our definition, as these people were the first cohort of people to be at risk of ICD-10 defined post-COVID conditions as soon as that code became active. For each of the data-driven, as well as the UO9.9 defined cohorts, we computed sensitivity and specificity, the average total variational distance, K nearest neighbors, as well as the incidence of each ICD-10 subchapter among people having each of these definitions of post-COVID conditions. On this slide, you'll see a classic table 1 of the cohort characteristics of persons with COVID, as well as the comparator pool. Groups were well balanced with standardized mean differences 2% or less on pretty key COVID incidence, as well as severity risk factors. The population had a mean age of 48 years. We had fewer males than females, predominance of overweight and obesity, as well as a high amount of current or former smoking, all common in US COVID cohorts. On this slide, you'll see the 10 highest prevalence ratios of ICD-10 subchapters in our data. However, we found hundreds that had a greater occurrence after COVID than in the comparators. Broadly, these can be summarized as respiratory subchapters, COVID-specific occurrences, and multi-organ involvement. Conditions which were more commonly seen in persons after COVID than in relevant comparators were generally consistent with a prior understanding of post-COVID conditions. COVID patients do appear to be more susceptible to both acute illness as well as chronic conditions. Post-COVID condition incidence from the complete collection of ICD-10 subchapters identified in the previous step, we found one or more codes were identified in 20% of people 30 or more days after COVID. We saw PCC incidence increased with age in that 7.8% of pediatrics, 17.3% of younger adults, and 33.3% of persons aged 65 and up met our definition of post-COVID conditions. The incidence did not change by year. We looked broadly at 2020 as compared to 2021. There were many differences between those 2 years, perhaps notably including the availability of vaccination as well as variants of the virus strain itself. In comparing the definition to UO9.9 code, the accuracy of these definitions to detect the presence of post-COVID conditions using the alternate method was worse than chance. And by that, we mean we calculated sensitivity and specificity both ways, not presuming which one might be a gold standard, and the sensitivity was less than 50%. However, the accuracy to rule out post-COVID conditions was high, with a specificity of the UO9.9 code to detect data-driven definition cases 98% and 82% conversely. I'd also point out that on this slide, we found about 3% of people received a UO9.9 code, but 19% had an ICD-10 subchapter consistent with a post-COVID condition. Here you'll see population level comparisons between people who had a data-driven definition of post-COVID conditions, as well as that ICD-10 code. On the left, the average total variational distance, as well as on the right with the K nearest neighbor analysis, we see consistently that people who do not have that UO9.9 diagnosis code in follow-up are a heterogeneous group. Here we're looking at ICD-10 subchapters and the symptomatology itself. While the data-driven definition was built on the presence of symptoms in a clinical record, less than half of people with a UO9.9 code also have a descriptive persistent symptom recorded alongside that code. Challenges specific to this study include both the inability to incorporate COVID vaccination information, given that the coverage is pretty poor in US electronic health record data with the dispersed distribution of the vaccines, as well as the time period that we analyzed here did not include the availability of SARS-CoV-2 specific treatments. Finally, persons in the comparator cohort who either tested positive at home or could not access testing and did not report to their physician would have been misclassified with their post-COVID symptoms attributed to the comparator group. This means that the prevalence ratios that you've seen here today are possibly underestimated. We had other challenges that are inherent to real-world evidence from secondary data, including that this EHR network is not a closed network, and so people who sought care outside of the healthcare system were not encapsulated. The propensity score that we used to create our groups of comparable persons may not have been properly specified, and therefore there may be residual or unmeasured confounding between the groups. And finally, the data lag did not allow for the time period to include contemporary Omicron variants, such as BA4 or 5, XBB, or since creating the slides, we have a new variant, the EG variant. In conclusion, symptom and UO9.9 code-based definitions alone capture different populations. In order to capture the true burden, scientists might consider a combined approach. Most people who receive a UO9.9 diagnosis code did not have a corresponding symptom in their medical record, such as loss of taste or fatigue. An algorithmic definition may provide greater sensitivity for identifying patients who may be suffering from PCC and for measuring the true burden of disease, particularly before the availability and routine utilization of specific ICD-10 codes, and given the lack of consensus-based definitions on this syndrome. Thank you.
Thank you so much. Great presentation. think there are some people approaching the mic. I'm going to take advantage of the fact that I'm here first. No, but I just wanted to ask you about something that's a little bit generic potentially, but we've done a fair bit of work on long COVID, and after trying different things, we've ended up using a tested negative control cohort instead of doing what you've done, which is basically a cohort of people who had some sort of contact with the healthcare system, but not necessarily a PCR or something related to COVID, right? Can you tell me your thoughts on, why you preferred that approach that you used and why mine is wrong?
I'm not going to tell you yours is wrong. I'll tell you why we made this choice. So the test negative design requires that people are testing, which has been a challenge throughout time in the United States, but also more recently as well. People are moving towards at-home testing. Insurance companies are no longer reimbursing this given the end of the emergency health declaration. And so we did not use the test negative design for that reason, but we also wanted to make sure that we were not using an approach that had a detection bias. And that's why, in addition to that propensity score, we forced a match on calendar month of healthcare system encounter and age group.
Kevin Haynes, Johnson & Johnson. Question on the 19% that had the long COVID diagnosis, but not any evidence of COVID. I mean, that's not a surprise, right? They tested at home. Is there any evidence out there of is that close? Like, are there others that have been looking at running these long COVID clinics and understanding what the percent of the underlying COVID that they had that didn't arise to medical attention? And then sort of a second question is there anything with regards to treated COVID versus not treated COVID? And I guess I won't ask about Paxlovid, but is there any indications of the treated or the intensity of the treatment of the COVID and its impact on the symptoms and the long COVID? So two pieces.
Great questions. So the 19% here are people who had the PCC definition according to our approach, meaning they had one of those ICD-10 codes, such as fatigue or loss of taste, or perhaps some of the more serious cardiovascular manifestations that rose up in the data. With respect to the question about treatment as well as vaccination, I think evidence is pretty compelling outside of Pfizer as well as within, that if you can more efficiently manage the acute illness, that the risk and as well as the persistence of those symptoms over time goes down.
Hi, I'm Teresa from Oxford. Your title is about changes in symptomatology. So I was wondering whether your work also concludes about whether we should have a change in the definition of long COVID as it has been evolving over time. And do we know much better what long COVID is and which symptoms are the relevant ones? Did you also look into that aspect?
We did not. No. By changes in symptomatology, we were referring to the fact that it had to be both a new condition after COVID they didn't have before and also staying in their record 30 or more days thereafter.
Frederick Nyberg, Gothenburg University. I was wondering, is there, regarding the timing during the follow-up of these, when you calculate the prevalences, is there any difference between the symptoms and the diagnosis, the U09.9? I mean, maybe I'm thinking maybe symptoms is something that's happening early and only when people have had problems for a longer time are they getting this U09, and then some people have already lost their symptoms. So maybe you're actually measuring two different things. So that's one question. And the other one is sometimes with US databases, there's a lot of talk about one diagnosis possibly being a rule out diagnosis. So how big do you think that risk is in your data that actually they're being seen, these COVID patients, for symptoms and maybe they don't have so much symptoms or so much problems as the number of diagnoses of symptoms would indicate?
It could be, for sure. I will say that the 20% incidence that we see here is lower than most other studies in the US, and also those US estimates are lower than most other countries as well. So looking over time as physicians become more aware of this code, perhaps more familiar with how it should be used or not used, we could foresee the U09.9 code having greater uptake. We present here only the first month that it was available.
Okay, thank you so much for
Thank
a
you.
great presentation, and thank you for a great session to all presenters. Thank you all for being here this afternoon. Hope you have a good rest of the day.